Thank y'all so much for welcoming us back. We're really excited to do this because we got so much more to share now than when we first participated a few years ago. Plus, heaps more resources are now freely available on our website. When I first found pediatric feeding, I fell head over feet in love with it. It's a super cool, unique area, really fun, and the therapy works fast with big, huge success and an impact on the family and the child. But because this is for Feeding Tube Awareness Week, I want to start by saying obviously, feeding tubes are literally life saving, and tubes give kids proper nutrition and hydration so they can learn and participate in therapy better. And they can be a relief as a backup should a kid shut down in therapy too. So, also, tubes can be a permanent part of life for some and for heaps of reasons that you'll learn about during this awareness event. And on the flip side of what's in this talk, there's also issues with kids needing tubes, not getting them, or having an NG tube, waiting too long to get the G tube finally. So we'll also talk about some examples of when this therapy is and isn't appropriate, like they have to be cleared to swallow safely. Also, everybody's here to learn and means well and wants to help families, myself included. Some of the ideas we're sharing today might be new or different or challenging, but the goal is to present information grounded in real evidence and families' experiences so that we can improve together to learn to better support the most important people in this conversation, which is the children with feeding disorders and their families. So also keep in mind while watching this talk, even though it might not seem like it, I'm actually a child clinical psychologist. I've got a PhD in this stuff. So for many of these types of challenging topics and concerns we're talking about, psychologists are the discipline for this stuff. It's what we go to school for. So it's a fit to lead this conversation in line of research. Feeding's literally vital. Next to breathing is the first and most important thing we got to do in life, connected to almost every other aspect of a child's life and development. No human behavior has got greater biological and social significance. It occurs multiple times a day, every day, and is one of parents' greatest responsibilities. So there's so many sayings about this. You are what you eat. Food is life. The way to the heart is the stomach. Food's good for the soul. Soul food. But let's talk about the social significance first. Eating's at the center of everything: the family, parties, celebrating, grieving, occasions, emotions, traditions. Feeding can be a form of showing love and gratitude in cultures. If a person doesn't eat, it can be a disconnect from the family, community, sharing, communicating, relationships, or even their identity. I'm from New Orleans, so hopefully y'all got an idea of the rich, wild Creole, Cajun, French culture there, or maybe y'all have been or plan to go. That's me and my older brother catching crawfish in the bayou or the swamp. But have a think about how this applies in your culture and your family, like over the holidays we all just had. Feeding issues are super common, even more so than autism, with estimates of up to 90% in developmental disabilities. It's often one of the top issues that gets parents to the doctor's office, leading to other diagnoses and thus services. Plus, feeding is so intertwined with other big related issues like toileting. But basically, everything else in a child's life and development. It's all interconnected. For example, their energy levels and their sleep. And every single day, every living being, in order of priority to survive, has to breathe, drink, eat, toilet, and sleep. So, despite the impression you might get from that first slide on the crawfish and the Vegemite and the Tim Tams, I didn't get into this field for the food. I started out with adults with mostly profound developmental disabilities in big residential centers. So, it was really refreshing for me as a psychology student to get some concrete answers and finally some simple solutions when I got into this area. So, I love the behavioral approach and starting to understand learning principles. So I knew about feeding tubes and modified diets for dysphagia and swallowing, and pica, which is eating dangerous stuff that's not food, and rumination, which is bringing up food and drink and rechewing it over and over. But I had no clue about little kids on feeding tubes needing to learn how to eat and drink by mouth. So on internship, I fell immediately in love with this specialty area. There's a huge range of severity and types of issues, widely varied diagnoses and conditions, all different developmental and skill levels, and even typical development with no medical issues at all. So my professor used to say you could line up all our patients in a room and people wouldn't be able to guess what links them together. or pediatric feeding disorders. Here's some examples. They stop making a product or they change it slightly, and kids stop eating or drinking. Parents shopping all over eBay, Amazon, trying to buy it all up, writing the company to get more. And it's really nice of the company to try and make the cups and help, but this is not the solution. Here, the treatment was that they got her to eat a different shaped chicken nugget, definitely not fixing the problem. Here, they got the company to deliver during the pandemic. But again, not a fix. Months later, another problem come up. She can't bring them to school. And this is common with allergy rules. So feeding issues can be so limiting when the kid's away from home. And this is serious. They can end up in a hospital. The parents have tried. It's not their fault. And they can't fix this on their own. They need expert professional help. So we're going to do a lot of myth busting today. There's a lot of misconceptions in this area. So you'll hear this called safe foods, and I'm sure y'all especially can relate to the cringe here because people have life-threatening food allergies. And fried chicken nuggets with their spared parts and mystery ingredients ain't safe. And broccoli and peas ain't dangerous or trying to kill people. So it's sending the wrong message. And the foods that kids do tend to refuse are actually lower allergen risk and way more safe than these kind of foods. So fruit and vegetables is normally what they refuse. And as we just went over, this is not rare. Uh, this little boy ate zero foods, was in Australia on a baby bottle, but inconsistent with his intake. They tried getting rid of the bottle to make him hungry, didn't work, and the family got really discouraged by ineffective treatment attempts, so they were trying to get a tube. In New Zealand, trying to raise money to go to a clinic in Austria, which is a shame because there's a treatment that works for this. And me and my colleague are specialists in these countries, which is really rare outside of the United States, where the proper treatment is overseas, not Austria. Here, they tried starvation for 3 days. It didn't work. And again, not a barely understood condition, not a rare disorder. Other articles will be saying stuff like a condition doctors don't even know about. And many parents have been struggling and trying to get help since their kids were really young. We made a checklist that can be taken to doctor's appointments to help and see if it's a problem. If you ask in this question, the answer is probably yes. So you don't need to fuss over whether it's severe enough or what to call it. Is it picky? Is it fussy? Is it a disorder? The diagnosis doesn't matter. So what's important is the individualized goals. So if they need help with any of these targets, they should be able to get it. And if it's mild, then the treatment will just be easier and it'll be quicker to fix. So, and the younger that happens, the better. This checklist covers 3 areas: their health, skill and independence, and behavioral and social impacts. Starting with health, a clear one is the food groups. If they don't eat several foods from all food groups separately, not hidden in the spag bowl sauce or in a zucchini brownie, easy, it's a problem. Another myth is that it's common to have a white or a beige or bland diet, but this normally all comes back to the carbs and the sugar and the starch. So the boy on the right, his diet's probably similar, and I bet they don't eat cauliflower or parsnip, which are white. But they may eat rainbow lollies, chocolate, or salty Cheetos, or Vegemite. All those things are not white and not bland. So the junk and snack food category don't really count it as a food group. This would be called other. And the most frequently eaten food group by far is starch. So often we have to work with parents focusing on trying to decrease all the starch and increase the vegetables and the protein intake especially. And the least eaten food group by far is normally vegetables. We need some green ones, not counting the corn and the french fries here. And many kids eat no fruits. And some kids made a few proteins or combos with protein in it. Sometimes the best we might get here is cheese. So other things, they're on formula or a tube or on supplements. They've got constipation, they're on laxatives, they've got poor growth, nutritional deficiencies, and it's important to note this can be based on their intake. You don't gotta wait for it to get bad enough to show up on their blood work to know it's a problem. And not eating enough, so not enough volume, inconsistent eating. A super important one is not drinking water at all, or drinking all your calories instead of eating food, solid food, grazing all day, eating a bunch of junk food, not real food meals, and refusing medication and supplements. Skill and independence is a big category. They might still be on a baby bottle, still eating baby food, don't know how to chew, not drinking from an open cup's a really big problem, not using utensils or feeding themselves, or their food has to be cut up and they can't bite off portions. I love watching kids eat when I'm out and traveling, and I'm often in such awe seeing them do all this stuff like it's nothing and it didn't have to be taught. Behavioral and social impacts also a big category. Parents are short order cooks. The child's crying, throwing, spitting, leaving the table. They're having really long, drawn out meals. Everything has to be a certain way. They're only eating sandwich made by dad with two ends cut off, warmed 11 seconds on the Paw Patrol plate. Other examples I've had, boy's mom had to drive around with a burner so she could cook his food in the trunk of a car so that it be at just the right temperature or freshness for him. Kids going all day at school without drinking, or not drinking if their mom's not in the house. I had a toddler only eating at midnight bowling because they had to have all the lights and the music, and mom was getting no sleep doing this every night. Eating on the couch or in the bed with an iPad, having everything delivered to him, not coming to meals at the table. Um, and this wrecks the family's lives. They're dealing with it every day, multiple times a day. Can't get a babysitter, can't travel. They have to pack all the food in the blenders, got to get a place with a kitchen. Can't go on a plane. That's a big one. They have a huge tantrum with all the smells of the food cart coming out. And many kids, if they go on a trip, they might shut down completely, stop eating or drinking, just due to a slight color in the chain in the yogurt cap, or maybe the one thing that they eat is not available or made slightly different in another country. And this temperature photo, this cracks us up every time, although it should be Chris Hemsworth in Australia. Also, lots of hype on ARFID being new and without a treatment base. And I was really appalled when I first started reading all these articles coming out, because ARFID is mostly just a name change. And they've done this for many mental disorders over the decades. So the pediatric feeding literature goes all the way back to the 70s, so 50 years. And I was like, how are they missing this? So I was really happy when the author of this review contacted me and asked if my pediatric feeding cases had ARFID. I'm like, yes, I'm so glad you asked. So she finally addressed this in print in this review, said there's a need for education and training of healthcare professionals and interdisciplinary team collaboration, and established treatments like behavior analysis should be considered. Yes, thank you. Um, so I'm not really fussed or wasting my worries about this, but we're more interested in individualized treatment rather than diagnosis. But if you are interested, this shows clearly the differences in criteria. The pediatric feeding diagnosis is more comprehensive and adds the skill and the medical factors and has to be a pediatric age. And RFID only has the nutritional and the psychosocial impacts, but they don't have to meet all the criteria the, to have the diagnosis, though, anyway. If you do want to know more about RFID, here's an article in the Blend Mag, which is a great resource on tube feeding, and they put out an issue at this time for Feed and Tube Awareness Week. So this new article is this article from last year is covering some misinformation, like what's mild versus severe, or people thinking it's mild if they don't have a tube, so let's treat it differently or not at all, and fussy and picky versus a disorder. So later, I'll talk about the toughest, most complex case I've had that others would have called mild or easy in the past. He was totally healthy, not referred early enough or young enough, ended up with a tube at 9 years old, and he wasn't even swallowing his own saliva. This is something we think of as a given, it's a reflex, but it is the most severe extreme feeding problem you can have. But it doesn't draw as much attention as overt problem behavior, sitting there and not swallowing your saliva. So this little boy had a huge regression in all his adaptive functioning skills. His mouth was constantly completely full of saliva, so he couldn't talk. And he wasn't using his hands because one of his hands he was holding his lips shut, and the other one he was holding a napkin because he didn't want it to drip out. So he had stopped doing all his activities and using the toilet, was back at nappies, out of school, and not sleeping with the NG tube. And we'll talk about him later. Uh, so the good thing is this treatment works regardless of the original cause, diagnosis, disability level, or tube status. And that's the sole point of why we published this article. So unfortunately, parents might be told their kid can't eat with no assessment or treatment data attempts to support that. Or this treatment's only for autism, or not. I've heard the opposite. Or that if they have cerebral palsy, the default, they need to go to speech and OT instead. Or behavioral treatment is only for bad behavior and not teaching skills. So I was really surprised and sad in Australia when parents first started telling me oh, we were told our kid couldn't do these things, or asking me, can my kid still get treatment because they don't talk and they don't understand instructions. So the treatment still works, and in the hospital, we mostly saw toddlers with developmental disabilities and medical issues. So this goes along with shifting a mindset from the if they can learn to do it to when, and what's it going to take. And it may just take more time, especially to teach chewing or for them to reach full regular texture or full volume. Although, we're still only talking about weeks or months. We're not talking about years here. And you'll see this in the next part of the talk. So just one example I'll never forget in the hospital, we had a little girl. Her parents were told she'd never be able to feed herself. And she's legally blind, and she couldn't even really find her mouth with a spoon. And she had lots of other medical and neuro terms along with that. And it took 8 weeks, but she did it. She learned to feed herself. So, as I said at the start, I think all this stuff I'm saying is good to talk about. When would this treatment not be appropriate or enough? So, if the child is NPO, they have aspiration, it's going into their lungs or down the wrong pipe, wouldn't be appropriate. Having dangerous, uncontrolled seizures or pain, having TPN, so they have an IV going into their veins instead of their stomach. They can't meet all their needs through their stomach. Or some kids, if they're of an older age and they have other behavioral issues like severe aggression or self-injury or pica or rumination, they may need more resources like an expert controlled hospital setting like I trained at in the US, like this one. With diagnosis, one thing that is important for treatment is that it's not body image problems like anorexia or bulimia. So seeing this literature, I was so surprised realizing children and adolescents with RFID were ending up in eating disorders hospitals with nose tubes, psych drugs, and talk therapy, which is not empirically supported treatment for this. It can be costly, overly complex, and restrictive. Also, people trying to develop the new CBT but there are better ways to treat these issues than adapting other stuff to it. So most of the pediatric feeding disorder literature is on younger kids with developmental disabilities and medical problems, and the hospitals max out at age 12 for the intensive program. So in eating disorders, there are some people specializing in applying ACT to it, which is acceptance and commitment therapy. And this might be a promising merge for us, or helpful for some people who are older in age and don't have developmental disabilities. So not using any real names in here. These are de-identified names that we put into the publications. This is Idale. She was 13. She had no diagnoses or developmental disabilities or other issues. She had a ton of previous failed treatments for years. Hypnosis, medications, all the disciplines, since she was 2 years old. She ate 0 fruit and veg and only 1 protein. And this was interesting to me because she could communicate her issues and said she always felt bad. She had sugar spikes and crashes, never felt full, always hungry, medication side effects, weight gain, fatigue. But as a toddler, she just would have been a typical pediatric feeding disorder case. So I was nervous and cautious taking her on. And this was the first time I worked with somebody over 12. I called home about it. I made sure there weren't any other bigger issues going on in the family or with her, and gave a disclaimer to the parents that based on her age, we'd have to see how it would go. But she was self-motivated to do this because it was having a huge social impact on her as she was going into her teenage years. So we'll talk about all her achievements in the next part of this talk. So, feeding impacts almost all other areas of life. And we wrote this review paper called Let's Not Wait and See on the many side effects and impacts on the child from delaying effective treatment. Children can't get those early developmental and brain years back. In the first couple years of life, you got an explosion of brain growth. And it's really similar with skills. It's so hard to teach skills the older they get. They miss that typical critical developmental window for learning. And similar with taste, so that for infants, takes them the quickest number of tastes or exposure to learn to like foods, and the number of food exposures it takes to get used to or like food increases with age. It takes way more practice. So, if not from birth, these problems normally start at around a year and a half, and that's when kids should get effective treatment. And if we just talk about toileting and sleep, you probably can't do toilet training if they're constipated or they won't drink or they have pain from straining. And it's hard to help with sleep if they got energy problems due to lack of adequate nutrition, or they're getting up in the middle of the night for bottles or tube feeds, or they got reflux. Um, Also, iron deficiencies has so many impacts, like their learning, their energy, ADHD, paying attention, and feeding impacts hormones, puberty, dental health, even walking and talking. Not to mention the social and family impacts, the healthcare costs, or if they have a tube, that could impact where they are allowed to go to school. So feeding is paramount, integral to life, and should be a highest priority. You can be overweight and even obese with malnutrition and starving of nutrients, causing stunted height. So, for obesity, they've started recommending drastic medical treatments like drugs and surgery for children. And, diet related issues can have a higher morbidity than most other public health crises we focus on. Also, just because they don't have a tube doesn't mean it's mild. So many kids need tubes and don't get them, and treatment could be even more dangerous and risky if they don't have a tube as a backup. And people are going permanently blind from their diet, including as young as 5 years old. There was a case where the diet was oat milk. So this review article was written by eye doctors urging early prevention based on diet instead of waiting for the blood work to show up bad, or getting severe skin problems that can be deadly from lack of niacin, which is a B vitamin, scurvy, the parrot's disease from not having fruit and veg, fresh fruit and veg, and vitamin A is making a comeback. The little girl in that article was no longer able to walk due to her diet. And this one's so sad. A 7-year-old who collapsed, went into cardiac arrest, and died. And they found his bones were deteriorating. His mom said she felt unheard, spent years thinking she was crazy, trying to get help all over. She was told it was part of his autism, which is not okay. Labeling the issue is not a solution or an excuse. So, a lot of this stuff, doctors aren't picking up on it, and instead they're running complicated, expensive tests. So, there's articles coming out from different specialists like ophthalmologists, dermatologists, and orthopedics. And it's important to point out that these things are happening in developed countries. We published this review of common generic recommendations and advice out there, what parents are told versus what the real research evidence is to the contrary. So, stuff like children won't starve themselves, they'll grow out of it and start magically eating when they see their friends do it at school. They're not ready for treatment or they can't do it. That it's okay because of their disability or their diagnosis, that it's fine if their weight or their blood work are normal, or that the child's making progress in treatment, but that's been going on for months or years, or that it's the child's choice and don't use rewards, or focus on communication first. But even if this were true, it's not okay to have inadequate nutrition and hydration in their critical developmental years. Even if their blood work's okay when they're young, it don't mean it's not brewing. And treatment can't take months or years without fixing the problem. Not ready or able should be because of safety, like aspiration, not because the provider doesn't know how to teach them. So we don't let kids decide on the medical treatments they have to have from this, like if they're going to get a feeding tube or a suppository for constipation. They need their parents to make critical life choices like sustenance for them. So letting them choose might decrease tantrums at the table, but it also decreases eating, which is the actual point of therapy, right? So it's risky, it can be harmful, especially recommending stuff like this for kids with feeding disorders versus a typical toddler. And it's not just us saying this stuff. So a parent started organization in the US called Feeding Matters have put out similarly friendly resources to try to raise awareness on all this. If you want to know more about some of the myths, we just wrote another article for the Blend magazine on this. Much of this comes direct from the parents telling us they're tired of being judged and feeling like failures and blaming themselves when the circus they're told to perform to get their kid to eat doesn't work, when no amount of bento box art or farm to table gardening is ever going to end up in actual eating of food. This is not a phase like One Direction or Jello Jigglers or Jazzercise. So here's another case example. And in that lunchbox, that's meat, not carbs and bread. So this is Bo. He was 11 years old. All these myths were true. He ended up with the worst slabs I've ever seen. He ate one specific bag of chips. He didn't chew or swallow them. He didn't chew. He swallowed them whole. He only drank one juice and not from a cup. And he had a specific way he ate, a spot at the bar, at home. This is the only arrangement where he would eat or drink with certain toys, and if one aspect of that was disrupted, he would stop eating and drinking. So I was really cautious in disrupting this. I was nervous he would shut down completely with no backup like a tube. And he had stunted height but was overweight, and the family had sought help since he was 2. They tried starving him, everything. He did amazing in treatment. It took 4 weeks every day. It took forever just to teach him how to close his lips around the spoon. We had to teach him all the other skills too. He shot up in height, but sadly, over time, he had a change in his caregiver at school. They let it slip, had some other life changes, and his eating wasn't as bad as it was before we saw him, but he ended up having seizures, and this was super scary and a sad story to hear from the family, from the parents' perspective 6 years later. And he was having hair loss and bone problems and stuff like that. So, but the good news is we did a 2-week booster recently when he was 17 years old, and there you go, he didn't grow out of it. And again, I was nervous. This is the oldest person I've worked with in feeding, but he did amazing, and the parents reported all kinds of improvements after. His skin, he had eczema, his licking around his salt around his mouth, and bleeding and scabs and stuff. He's doing great. 2 months after, the mom sent us this photo and message, and she said they call him the rainbow kid at school because of his lunchbox. So we still keep up with them. He is absolutely smashing it, and he's made his parents have made so many amazing comments telling us about how he's doing in follow-up. And she sends videos, and we can actually tell just looking at his skin and his coloring and his hair. Or misinformation, like if they eat in McDonald's every day, then it's okay because the parents have enough to stress about already. Imagine how we'd feel if physicians operated this way with us and our medical issues. Ironically, what we hear directly from the parents and what the research says is the exact opposite of this. Parents are so relieved to finally not be getting dismissed and to get real help. Getting effective treatment is actually what reduces stress, and this makes sense. I don't get why so much time, money, and effort and research is being spent on asking people about their problems instead of trying to help them. Actual database treatment research. I want help before I go blind from my diet, not to talk about my stress and feelings about it after it's too late. So people may be well-meaning, trying to reassure the parents. And I've had providers also tell me how they've been impacted by trying to do treatments that were sold in workshops but didn't work. But professionals in positions of authority who aren't psychologists or experts in feeding, they haven't seen this stuff, the results of the advice they might have gave when the kid was 2. And then unfortunately, I am later. So it's concerning to be advising parents on something so critical. We need to do what's best for the family and the child and what the evidence actually says, not what makes us feel better or what's easy for us. So treatment has positive impacts on the child's emotional and behavioral functioning, in addition to reducing stress like we just talked about. Parents give really high ratings of the treatment. Just in our review, there were over 400 cases reported from multiple sites, and they describe improved quality of life, and treatment can increase child happiness. And we'll go over some more of this in the last part of this talk. No negative side effects have been reported in follow-up. Not all kids have negative reactions to the treatment. And if they do, they're brief and the parents still rate it high and prefer it. Often the meals they dealing with every day before the treatment and the impacts of the feeding problem are worse. Think just of NG tube insertion and tape changes or dealing with constipation. I think of that saying, pick your battles, and besides breathing, what's more important than eating and drinking? If you're going to pick one, this is it. And just emphasizing this is all coming from real parents getting proper treatment and support. However, much of the discussion in this area is not data-based or in peer-reviewed scientific journals, and not by competent experts in this area, like firsthand from the informed parents who've been through it properly and clinical psychologists who are trained in it. People call themselves foodies and are food lovers, and there's so much hype about the opposite of food refusal with the dieting industry and obesity concerns. It may be hard for people not in this area to imagine that kids won't eat even ice cream or chocolate birthday cake. So parents get a lot of flack and get misunderstood. So why might people end up with eating problems? So it's really complex. Multiple reasons can contribute and be intertwined. Physiological and genetic and developmental and metabolic risk factors. These could be things like prematurity, food allergies, cleft lip and palate, reflux, breathing issues, aspiration, so food or liquids going in their lungs down the wrong pipe, structural issues with their throat or their tongue, motor delays. But some people have no physiological or medical cause or diagnosis and have typical development like IDEL we talked about. Another factor, learning history and skill deficits. So because they weren't medically able or allowed to eat or drink, they might lack exposure, practice, strength, and coordination. So they didn't learn how to chew, close their lips around a spoon, drink from a cup, or feed themselves, so they don't know how to do it and they didn't get the chance to practice. An example of this might be a preemie that spent their first 2 years in the hospital, had a tube or were intubated, had a bunch of surgeries. They missed that typical developmental window to learn feeding skills, so they might have weak muscles, be uncoordinated, and also could be that the child refused to do it once these things were resolved. So even when the medical or physiological issues are resolved, the child may still not know how to do the skills because they lack practice and exposure, or they may refuse to participate and learn because it's hard or unfamiliar for them. So we work on both factors, encouragement and help, to get over the hump of not being willing to try or participate, so that we can help and teach them to learn and practice the mealtime skills. And many children could do this if they're safe to swallow and we know which foods and drinks are allergy safe for them. Environmental factors. An example would be a conditioned aversion. Maybe they tried to eat and it was unpleasant, for example, vomiting or having a bad experience. Y'all might have some personal examples, something you ate or drank while you were sick, or you got food poisoning and then you didn't want to be reminded of it again. We might have some memories from our teenage years, which y'all call schoolies, saying you're never drinking again. Other examples could be a choking incident or allergic reaction. So even when the physiological issues are resolved, you're not sick no more, there might be environmental factors that are the biggest reason that feeding problems persist. They keep going on, and they're the actual key to treatment. Part of the assessment is doing a direct meal observation, so directly watching them eat or drink and looking for reasons and things we can change and see and change in the here and now. Like the behavior of others in their environment. What happens when the child does or doesn't eat well? So for example, if they refuse, do they get a break from eating? Is the spoon or the food removed? If they vomit, do you think, oh, they must be full and in the meal? If they cry, do they get a cuddle? If they spit something out, do you think, oh, they didn't like that one, let me get something they like better or something they want? If they cry or refuse, they're out of their seat, up and down, do you get toys or a TV to distract them or help them stay seated? What happens if they hold food or liquid in their mouth and they don't swallow? These are all really common natural reactions most feeders do. So it's not saying it's the parent's fault. They may feed all their kids the same and only one's got a feeding problem. But the cool thing about this is it is the key to the solution, and it's in our control to change. We wrote this review paper that has a full table of disciplines and specific roles. It's very important to note that they still have to have feeding expertise. So before the treatment can start, and the medical and physical stuff has to be evaluated and treated. They have to be medically cleared and stable and able to swallow safely. So we have to have guidelines from the other disciplines, especially for food allergies and swallow safety. So, in this category with this audience, y'all are probably very advanced in this area. So, a gastroenterologist and allergist might need an endoscopy with biopsies, could have food allergies not showing up on the outside. And, even with that test, you have to consider the timing of it and were they on steroids or elimination diets during it or reflux medications. Uh, and having a camera down the throat, checking out if there's a mushy or soft throat, narrowing rings or damage where food can get stuck in there. um, and this test requires sedation, so there's guidelines on how often you can do that. Also, blood testing for specific food allergies, or in Australia I find a lot more skin pricks. Looking at if there's problems absorbing nutrition, things are moving slow through the tract, reflux, vomiting, the teeth, bowel movement management of constipation, looking at medications, and is there any kind of stomach infections or irritation. So dietitians would be helping with tube cuts and looking at their fluid needs. And a real big one is label reading for allergies. So there's lots of nuances, whether it's cooked or uncooked, the amount of it, different formula types, intolerances versus cross contamination, like latex with bananas. Having a contact rash, plus just caregiver beliefs or preferences, like if they want to do gluten-free, casein-free, or if they have some superstitious thoughts about foods or drinks versus a true allergy. And blood sugar conditions, they have to make recommendations on intake to keep that stable. Special diets needed for certain conditions like PKU, or if they have reflux or vomiting or celiac. Absorption and interaction of supplements, like taking iron with dairy and that impacting constipation. Also, nutritional deficiencies, supplements needed, and of course their growth. But if they don't have a tube or food allergies, a lot of times the dietitians are more useful after the program. Many families see them as a default, they're sent straight to them, but they might recommend supplements that the kid refuses to take, so it really doesn't help. Or they tell the parents, oh, your diet and hydration's bad, and the parents already know, but they're like, I don't know how to fix it. So anyway, we have to start small and target full variety in water, and the results happen pretty fast within days. So dietitians may be more helpful after the treatment when it comes to looking at their volume needs and their growth. Speeches play a huge role in swallow safety, looking at aspiration. Our hands are totally tied if they're not cleared in this area. And in the hospital in the US, we would work together with them to prep them to get successful swallow studies. And they had the feeding expertise for this, which was great. So children need to know how to participate and how to eat and drink for the test to be helpful. But similar to the issues with the dietitians, the speeches might not be able to assess their oral motor skills or get them to eat and drink for the swallow study if the kid refuses or doesn't know how yet. If the kid's not participating, you're limited in the results you can get from that assessment. So these tests also have limits, like we were talking about with the endoscopy, how often you can do them because of the radiation. There's time limits on the x-ray and the barium exposure if they're swallowing it. And even though these tests are medical, there's still subjective interpretations of the results and inconsistency in the recommendations from them. And the behavioral therapist needs to know this. And if there's swallowing issues, the speeches can recommend consistencies of liquids and solids that are safe for them. So others, this psychology may overlap with the behavioral therapist. OT, they can look at fine motor skills, seating, and adaptive equipment. I love social work. They used to help the families with the resources, support the family going through it. And Child Life and Peds Consult, I also love them so much. They would prep and help with cooperation with medical procedures, and they would accomplish incredible things with kids going through really tough medical procedures. So many kids with feeding problems, they don't just refuse food and drink, they'll have difficulties with procedures. And here, they're not getting them done. They're not getting to the dentist, and they're not getting their blood work done. And this could be done so much better and easier without all the struggles with similar intervention techniques that we use in feeding. Outside of the specialized hospital settings like the one where I train, you need way more expertise and responsibility in this area. So, like me in Australia, I'm doing this by myself without that. Other disciplines are often most important in intake before you even start the treatment, and we have to know about all this stuff. You hear blindly people trusting what's said, like taking it lightly. Oh, they're medically cleared. It's been ruled out, like it's 100% sure. So with the assessment, we need to know, are they really cleared? Do we have all the information we need to start? We also need to do a direct observation of the meal and their skills. Aspiration is very important. You can have silent aspiration with no signs of it except chest infections. We need to know the signs of it for different ages, and then the testing and treatment recommendation that we get for this, like the textures, consistencies, and when they're going to repeat the test, and also to know the limits and subjectivity in those tests and how successful was the test, the swallow test that they got. So do they need a hospital or in a disciplinary team setting instead? Or the case and the circumstances in your competence, do you need to refer or consult? And what can you do on the wait list to prepare the child and the family if someone is going to be able to see them? So you can have physiological, behavioral, and skill reasons all behind the exact same behavior, such as gagging, coughing, emesis or vomiting, and food allergy reactions. So we have to look at the why rather than just what it looks like or what it is, and we have to know how to handle that. So a common one is gagging and vomiting. That can occur because you've got a structural issue with your throat, or there's aspiration or an allergy, versus is it because the child doesn't know how to chew good enough, or they need practice to be able to get used to texture, or they don't like texture, versus does the gagging occur when the broccoli comes out and then they get the baby bottle or an iPad or comfort. The same with food allergies and emesis in the hospital. We'd have a kid eating foods for weeks, and the parents were watching in an observation room, and the minute we started parent training, a lot of food allergy symptoms were being reported, like, oh, I got an itchy throat. So we need to know about blood sugar recommendations. Before we start teaching chewing, we need to know that their teeth are okay. What medications and supplements are they on that could affect the meal, like appetite especially. Kids being put on stimulants, and which can cause nausea and loss of appetite. On the flip side of that, kids being put on antipsychotics if they're obese or overweight, causing weight gain. Other issues that could impact the meal, like breathing, seizures, or heart conditions. So bowel movement is a huge one. They need a good regimen. It needs to be preventive and not reactive, because kids may vomit or stop eating if they're constipated, and that can really impact your meal. And many of these kids already don't have enough water or fiber in their diet. The top food allergies, we need to be extremely careful about what foods are being given. I'm like that even with the other family members and the lunch we bring in. In the hospital, we had extreme sanitation procedures and separate items and stations and all that. We need to know reaction signs, safety procedures, especially if you're in home. Do the parents have an EpiPen and know how to use it? If you're remote, how do you get to a hospital, or stuff like that? This has never happened to me. I'm terrified of it, thankfully, and it's nice when the parents or doctors or nurses or ambos. If you do decide to take the case, one big thing we need to estimate is how many weeks does that child need? What is the treatment intensity that's appropriate for them? And what are the resources we need, like equipment or seating or staff? What do we need from the other disciplines before and during treatment, and how to monitor symptoms and figure out if we need to refer and consult. And support needed for the caregivers before, during, and after treatment is huge. Do they have siblings, and what are their needs? Maybe the mom's pregnant. When is she due? Do they have any family help or friends? What are their jobs like? What's going on at school? and also to be able to provide them some psychological support, like resources on acceptance and commitment therapy, and help them plan all this out to do the program. So in the hospital, we had experts in everything, and we all specialized and referred. I really miss that here, like, because I could just focus on feeding, but, instead of just sleep or behavior or something like that. So another important one is the starting point. So what foods, textures, liquids, and bite size are you going to use? And then how do you progress those in treatment? And how do you prioritize and individualize their goals over time based on their nutrition, their hydration status, their growth, their texture, and their skills? Another big one we'll talk more about later is caregiver training, to train them to do what works and get yourself out of the picture, and how to generalize to other settings when they're away from home, when they have babysitters, grandparents, if they're traveling, and when they go to school, and then how to make this last long term. So this article includes a full 5-page physician's clearance form that you can use. So it's probably not going to be a feeding expert that's filling these out. So the form clues them in the symptoms that may not be picked up, even if their labs are okay, like when we were talking about the scurvy and the pellagra and the rickets. And the testing that they may need. And it's very important to say this form is just a minimum standard. We have to have the knowledge to participate in this process. You can't just say, well, they were cleared, the medical issues have been ruled out. So we need to know that everything's covered and safe before we start, and especially for us, we're doing this in-home in Australia alone. We don't have an expert hospital team like we had in the US, and so we're super cautious about what we do here, and often have to kind of over participate in our role in this process. There's lots of pseudoscience and fads in feeding, and now, like we were talking about, lots of hype with ORFID. So we wrote this treatment review article, and the Association for Science and Autism Treatment made a resource out of it. It shows that behavior analytic intervention is the only well-established treatment for this, with 50 years of evidence behind it. The study quality is higher because they have experimental control and objective outcomes like actual eating and drinking skills, rather than just subjective surveys or reporting only their weight. Oddly enough, the only few quality studies like that on the non-empirically supported treatments were done by us to compare them to behavioral treatment to show that they don't work. Also, ironically and sadly, most people don't get this, especially outside of the United States. So it's a direct opposite what the research says versus what people are getting. In our sample, kids had up to 11 years of failed prior treatment attempts by up to 12 different disciplines and approaches. So sensory and play stuff, play with the food, go to a sensory integration gym before the meal, lots of oral motor stuff that don't even involve food, like brushing and vibrating and stretching the mouth or buying expensive equipment. Things called desensitization, which is the wrong word, working on stuff other than actual meal materials, real food and drink. Just one example in treatment, I had a boy, he was packing bites on his tongue instead of moving them to his teeth and chewing, and it was causing him to gag and vomit, and it was scary. I was worried he would choke, and the parents told me he was actually taught to do this, which is dangerous and actually increases gagging to hold it on your tongue instead of just getting on and chewing it. So I've also had follow-ups where the parents let the kid keep going to therapy after the feeding was already resolved. So I don't know why they were even working on it, but taught the kid to spit food out, expel again, and then I had to get back in there and undo that. So now I tell parents, don't let therapists keep working on feeding anymore. Now the parents are the experts on how to feed their child. So kids should be getting this treatment first, by default, when they're young, not as a last resort when they're older, when the other stuff don't work. It's all really defeating for the parents, thinking it's their fault, their whole circus, their food shapes, and their cooking wasn't good enough. And hearing parents' stories of trying to get help is appalling, but it's easy for us to reassure them that this actually works and give them hope. So most of this research is from specialized hospital settings in the United States, and there's only a handful of them. So the treatment is intensive, which means every day, all day for weeks, and not just an hour a week. We eat like 5 times a day, 7 if you're a Hobbit or a Cajun like me. And it's often emphasized that it requires a multidisciplinary team, which is 100% correct for the initial assessment, clearance, and consultation. But in the direct treatment, the actual therapy sessions, the behavioral therapists are the ones doing the empirically supported treatment, and the data, presenting the data that makes the difference. So there are plenty of multidisciplinary feeding hospital clinics worldwide that don't have trained behavioral therapists to do what makes it an empirically supported treatment. This is a review specific to tube dependence. Especially with tubes, another widespread treatment approach is hunger provocation. If it were that simple, they're hungry, they'll eat. So removing their lifeline doesn't teach them how to eat or drink or be independent. And again, they're in their critical developmental brain years. They need brain power and energy to be able to learn and participate. And there's significant risk with this approach: nutritional deficiencies, weight loss. It can't be done if kids have blood sugar issues or seizures. And sometimes it includes non-empirically supported techniques like psychoanalysis and play, requires checking their blood sugar regularly, all while celebrating, touching and kissing junk food like custard and cookies. So parents report being scarred from this and it not working. They said they felt it like it was wrong, but they were going along with it, especially in a medical setting like a hospital, and that they thought the professionals knew better than they did. So their examples told nonchalantly their kid's blood sugar was so low they don't know how he was holding his head up. I don't get it. How are you supposed to learn or do anything like that? If my normal eating routine is disrupted just for a few hours, I feel terrible. So some more myths I hear: just normalizing weight loss, less variety, unhealthy foods, that it takes time, that there are ups and downs, all in the line with the kind of idea that kids won't starve themselves and that they should have intrinsic motivation to eat, so don't use rewards. These kids have a tube for a reason. And for them, eating might have been paired with pain or discomfort rather than pleasure. So it may be really hard for them to learn all these new skills before they get to experience the joy of food. Also, as adults, we widely vary in how much we're motivated by food or not. Not everybody's a foodie. Doesn't require hunger or deprivation. And you can see those red lines. You can see how the tube was gradually reduced. The treatment works fast and it is consistent. And this was done in New Zealand by Dr. Sarah Taylor. The dreamy part about this is she had a 19-month-old, so you can see the benefits of early intervention. And she used full nutritional variety, all the food groups, and the child gained rather than lost weight. So in treatment, the process works similar for kids without tubes with their preferred foods and drinks. So we don't ask parents to cut it out without help. We do it gradually and help them. And this is not saying that hunger is not relevant. We do set a structure and a routine, and we shift the timing of their tube feeds or meals around. For example, trying to make sure they're not full before meals. And also, they can earn extra food and drink if they want after the meal, so they can regulate their own volume. But this all depends on their growth, their health, and is all individualized to the child. So this is the toughest case that I've ever had that I was talking about with RFID earlier. So this is Aloy. He didn't get referred early enough when these problems started. He was 100% NG tube dependent, not swallowing his own saliva, and had stopped using his hands, talking, going to the toilet, wasn't in school. He had 2 hospitalizations, the full gamut of medical workups. And he didn't respond to feeding treatment for 10 days, which has never happened before. We ended up having to work on his behavior across his whole entire day. And when he finally swallowed some saliva, we were all crying, couldn't believe it. His mom was jumping up and down in the kitchen, hugging him, saying, he can swallow. We were using head torches to be able to see in there and doing major mouth clean checks to collect data on his swallowing. So in this graph, this is his volume of intake, which is the bars, and his weight is that black line. So you can see from the orange bars at the start, his mom didn't want to cut the tube at all before he was eating and drinking by mouth. And then it was gradually cut as oral intake increased. So The blue is liquids by mouth, and the green is solids by mouth. And he gained rather than lost weight, and he was off the tube in 23 days. He got to 94 foods, and in follow-up, still had no tube, and the gains maintained. So the treatment was solely behavioral. There was no hunger provocation. He didn't have weight loss and didn't have limited nutritional variety. And just a very important point on case severity and the misinformation around it. People might say a tube is more severe, like it's black and white. That's definitely not always true. Like we keep saying, tubes are literally life-saving. So it can be more risky if there's no backup means of nutrition and hydration. If the kid shuts down, for example, a kid on a baby bottle, or like Bo, we were talking about with his routine and his lunchbox I showed y'all earlier. And with tubes, the kids can be healthier and in a better place to learn and participate because they have good nutrition and hydration. Like we were talking about, you need that to learn and participate, and for your energy and stuff. So the severity of a case really takes feeding expertise to judge, and the data actually while you're in treatment and how they respond. As complex as it all is, all the different challenges that can arise during treatment, it's not just medical versus skill versus behavior to try to determine the severity. And if you think about it, that 7-year-old news story that we talked about where the kid actually died, he didn't have a tube. Teenagers growing permanently blind, they can't see anymore, they don't have tubes. Bo didn't have a tube. So, and a lot of times, like we were talking about, kids can need a tube and not get one. I've seen some kids disturbingly underweight here that I can't even describe that didn't have a tube. Or kids keeping NG tubes long term, which are really a pain, and not getting the not being able to get the G tube stomach surgery soon enough. So this is just a simple overview of the gist behind the treatment. It's done in home, which is really nice because they can get outdoor time in the park or the playground or go to the shops during the breaks instead of being inside a hospital. And then later we also can do cafes and go to school and do family meals. The treatment is short, meaning weeks, short term, intensive, so many brief practice opportunities all day, every day, so practice can make perfect. The intensity must be appropriate for the case's needs and the severity of the feeding issues, and it needs to work quickly because of the critical nature of feeding. So how many weeks it takes depends on the child's needs and progress, and the minimum is normally around 2 weeks, although I've had some cases graduate earlier than that, and the longest we've done is 7 weeks, and this does include the weekends, and that was Aloha with the tube graph I just showed y'all. In the US, the admissions were 8 weeks, so 2 months long, and some kids had to have 2 admissions, especially for something like regular texture and chewing after they have gotten off the tube. So we only work with one child at a time, so there's tons of flexibility in the schedule for the parents. We work directly with the child to find out what specifically works for them before having the parents try to do it or giving the parents recommendations. So once we know exactly what works for that particular child and they're succeeding, we start to work on gradually getting ourselves out of the picture and helping the parents do it by themselves. So the amount of parent support in training in this process is huge, and step by step. So we're right there next to them at first, and practicing together. So we do behavioral skills training. We'll give them a written protocol, have them observe a meal, go over the protocol with them, and do a role play. So have them feed us so they can practice. And then we individualize how we fade them in and us out, whatever works for that particular family. So at first we might be sitting right next to them, and then we might be working on leaving the room and watching via Skype, and then giving them feedback instead of all during the meal to do it after the meal, and then have them do some remote meals completely without us and video it, and then we'll look at the video feedback after. When we're with a family and they start feeding without us, they are our lives. We're on call. We run in early or after hours. We Skype in. Whatever they need, we do. So we're their ride or die. Here are some stories. At 6 a.m., I was still in bed, and my assistant had my stuff packed. He heard I was on the phone, and we had to run in for breakfast. 7 p.m., one time the liquids didn't get finished, and we had to go help. And or maybe the child, their first meal that they do in the afternoon, their first dinner without us, they might start some new things like saying they're full or something like that. I've had cases too where we had to hide a camera to see because the child wouldn't show the behaviors when we weren't there. They would eat okay. And then I've had some where the whole entire program they do fine and they don't have any problems. And then only when the mom's alone on video we see the problems. And so we can try to help that way. So and then during the first couple weeks for follow-up, we look at the plate pictures and the videos for every meal that the family does, and we communicate regularly on a shared data spreadsheet. We don't start off with a big steak and salad. The starting points, such as the texture and the bite size, it's individualized for the child based on their feeding status, the assessments we've done, and their choices and participation, as well as input from the parents and other providers. We first do assessments directly with the child for them to make choices of the targets, like their foods, drinks, and medications if they're willing, and their incentives or what they're going to earn. We keep doing this throughout, and I'll show you a case example later. Increases are made gradually and are data driven. The same with tube cuts and preferred food or drinks. We don't do this abruptly. We give the parents help and do it gradually. This is all tailored specifically for the child based on their individual starting point and progress. And small changes are made fast every meal if needed. So there's a huge skill teaching piece of this in them learning how to do their mealtime skills like chewing and cup drinking and using utensils, because even if they're hungry, they might not know how and they might not need lots of help to start and learn. So we do the teaching in the context of a real meal with actual materials and food and drinks. The idea behind the treatment is looking at meals from the child's perspective and putting yourselves in their shoes. So focusing on the simple things we can see and change. What is their motivation? What do they want? And what do they get? What happens before, during, and after good versus negative mealtime behavior? And how can we flip that around to increase their success so that they get what they want for eating and drinking well, rather than for crying, refusing, or spitting out. We can simplify this into three general areas that we can change to optimize their success. So escape or avoidance is the most important part. In assessments, this always comes out as a reason for refusal. It's the most common thing feeders do when you do an observation. They remove the food or drink if the child refuses. So if given the choice, they don't want to eat or drink, they have to have the right help and prompting to safely get over the hump to practice and learn. And it's very important to get the difficulty level right for that individual child. And the requirements set have to be achievable for them so that they can contact success. The more they practice eating or drinking, the easier it is for them, and the more they will like the foods and the drinks, and the less they will want to avoid and get out of it. And this also includes being honest and upfront and sticking to clear rules and instructions. This is really a case of practice makes perfect. The more you eat it, the more you like it, and the easier it is. Another part is interaction and attention, praising them when they do well if the child likes it, and not reacting and losing your cool when they ain't doing well. So not reacting or talking about mealtime problems during the meals, staying calm and neutral, not showing if you're upset and frustrated. So not telling them off, fussing at them, reprimanding, nagging them, coaxing, comforting, threatening, or bribing them. And the interaction has to be individualized to the person, what they like, if they like it at all. So this is often way underestimated in feeding, and I think it's actually connected to escape and avoidance, like taken as either pressuring them to eat or a sign that the parent is about to give in. So in the hospital, we directly tested these factors, and I remember walking in an observation room when I first started, and there was lots of crying and refusal, and I assumed it was a escape avoidance test, but it was actually attention. Another part is incentives or rewards when they do well rather than when they aren't. So we party it up when they succeed and make it fun, put on their favorite music and sing and dance. We get ridiculous. We've had parents gift wrap new toys for them as presents to open like it's a holiday. Como, the case I'll show you later, his sister picked different activities for one-on-one special time with her mom. And one of the cutest was dancing in the rain with an umbrella. So we blare the speaker out the window and dance with them. So they can do messy stuff, things they're not allowed to have that often, like foam or hot and cold color changing cars or even sparklers. So with the preferred food and drinks, instead of them filling up on them before meals for free, we reserve them to keep them special, to make sure they're still excited about them. And then they can have more after they finish their required plates, so they can still earn small amounts of their favorites. And the same with the electronics like the iPad and the TV. So most kids in the program earning way less than they were getting for free before we started because we're stingier with the stuff. So what's cool about their favorites is in terms of food and drink is they change because they learn to like so many new foods. So it gradually starts shifting to where they're ironically earning healthy things like things we introduced in the treatment, like watermelon. That's an example you'll see of this in the last part of this talk with Como too. In the beginning, this has to be planned out right and needs to address all three of the factors. It can't be you eat a whole plate of Brussels sprouts, you get to go to Disneyland. Or if you drink all your formula, you get your iPad and a bunch of lollies, but you get the iPad for free all day and you just ate a whole bag of lollies. So when done right and paired with exposure requirements for escape and avoidance, things that hadn't worked in the past can be really helpful. The amount of incentives has to be matched to the difficulty level. And as meals get easier, you can phase them out and simplify it so they can have a more natural meal. Now, on the intrinsic motivation thing, don't use praise or rewards. In addition to what we talked about earlier, that eating and drinking may have been paired with pain or a bad experience for them, and that they lack experience with food, especially positive ones, plus that it's super hard for them to learn mealtime skills when they're older, and they miss that critical developmental window. Think about how common and accepted it is to use rewards for toilet training kids. And as adults, I'm sure you can relate to not needing the rewards anymore for this. So as adults, we can choose to do things that we really don't want to do or like, or that are really hard because we know the consequences, we know we have to, and we know what we get out of it. And we're here to teach the kids and help them grow, and this is why informed consent and legal age exists. So, plus, most people probably would stop going to work if they didn't get their paycheck. And think about how good it feels to get positive feedback from your teacher, your boss, your partner, or your coach when you worked really hard on something. I know I do, and a big example here is public speaking. I'm putting myself out here. This is super hard for me, but I put a survey link at the end of this talk, and as much as I'd love to hear all good stuff, I specifically ask for the bad too, so that I can make it better and more helpful. And the same with the families. We ask them to tell us straight up, and that's what the last part of this talk is going to be on. So treatment needs to be function-based and individualized. So based on each person's why, their own motivations, and follow a least restrictive progression, not based on a blanket generic philosophy or one's own opinions of subjective feelings or a cookie cutter approach. And definitely not over what the parents themselves are telling us they want and need and what's actually been shown to work. So if somebody tried to get me to do this talk by offering me a chocolate pie or a donut, that would be a major backfire. That's a punishment for me. So most kids won't eat or drink for praise or incentives alone. So just emphasizing again that this first part, the meal requirements and the help, is the most important part of success. The other two, the praise and incentives, make it more enjoyable, provide motivation and encouragement. They help to learn the skills and increase their independence. But observers often focus on those things, like the iPad was the cure, but most kids had already had their iPad and still needed this treatment. So this is way more detailed in planning out all these factors together. And this is why feeding practitioners must be competent to treat escape and avoidance properly, and while carefully assessing and teaching skills, as this is a risky and specialized area. You can probably relate to this idea more as treatment for anxiety and phobias. Exposure is one of the most effective therapies psychology has ever had, and this is very well known and accepted. fun in longer workshops. We go through this kind of stuff, and it's way more comprehensive and individualized than something you would see in pop culture like Freakonomics. So these are the principles that make the world go round for all of us, every living being. Many categories of things we want to get or get away from: items, activities, interactions, daily life tasks, things we like and things we don't like to do. So we can make lists and make hierarchies within each list, layering them with each other so that we're matching them up, taking into account learning principles like the time and the frequency, how often they get it, the size, the quality, and satiation and deprivation. So me and my partner use this on ourselves every day. A good example here is one person's fiesta is another person's cilantro. So there's so many things that came up doing this that could go either way, depending on if a person might either love it or hate it. Like for some people, oysters are a luxurious treat, and to some people it's not. And exercise is on both the love and hate lists here. And some people like to do cooking and cleaning. Taxes, maybe accountants don't hate them. So the second part of this next talk shows a really neat case example of this with Como and heaps of other exciting achievements that kids have made in feeding. So we're saving all the best bites for last.